Hello everyone, I'm Sharon McDonald, an epidemiologist here at GrassrootsHealth. We recently published a paper that showed that vitamin D serum levels in the range of 20 to 100 nanograms per milliliter are not associated with the occurrence of kidney stones. This analysis used the data from our GrassrootsHealth D-Action study. Today I have the pleasure of interviewing Dr. Garland, who is a professor at the University of California, San Diego, and is a leading researcher in the vitamin D field. Dr. Garland is one of our expert advisors here at GrassrootsHealth and a main author of the paper. So let's jump right in, Dr. Garland. Why do we hear so much about vitamin D and kidney stones?
Well, Sharon, thank you for asking the question. I think there are two reasons. One is that when people have kidney stones, they're told that the kidney stone has some calcium in it. And they hear that and they think, oh man, it's due to the calcium. But the reality is that many people have very high levels of calcium in their urine, but they don't have kidney stones because they lack the other part. There's two compounds that have to combine to make a kidney stone. The most common of these, in 60% of people who get the stones, is called oxalate. And it comes from a number of different foods that contain this compound called oxalate. And when it combines with calcium, it causes a kidney stone. But the calcium itself does not cause kidney stones. In fact, intake of calcium reduces the incidence of kidney stones. The same thing applies to vitamin D. Even though it increases absorption of calcium and even some of the urinary concentration of calcium, it does not cause kidney stones. People that consume more vitamin D have fewer kidney stones. So that's one of the reasons. It's just a misnomer, a mistake. The other is that there was a study done years ago that found that women who consumed 1,500 milligrams of calcium and some vitamin D, 2.5% of those women over a 15 or so year period ended up with a kidney stone by their own reckoning. And in the group that didn't get calcium and vitamin D, 2.1% ended up with a kidney stone by their own reckoning. Well, it's barely significant. It's not clinically important. It's just a little tiny itty-bitty difference that could have flipped in either direction. But as life had it, it turned out that the people that had the calcium and vitamin D had this little tiny, little bitty bit more of kidney stones. Well, no doctor in his or her right mind would ever make a decision about giving someone a cancer-preventing agent because some of the women who took the agent had a 2.5% risk versus a 2.1% risk in the placebo. It's meaningless, but it somehow got into the literature and got into common parlance, and they get associated. Fortunately, we're getting away from that.
That study that you're referencing is the Women's Health Initiative, and the vitamin D intake was only 400 international units per day, and the calcium was 1,000 international units per day. Other researchers as well have written about this, and Dr. Haney, our research director, has indicated that in addition to the lack of adjudication of the cases, that the level of intake is generally considered insignificant, and since vitamin D and calcium were given together, it is impossible to attribute the slightly higher risk of kidney stones to vitamin D rather than calcium.
Is there anything unique about the GrassrootsHealth cohort that allowed you to rigorously assess the relationship between vitamin D status and the risk of kidney stones?
Oh, is there ever? The GrassrootsHealth cohort has the highest intake of vitamin D of any cohort in the world. And up until the GrassrootsHealth cohort, there wasn't any cohort in which we could study intake of more than about 600 or so IU a day of vitamin D, international units a day of vitamin D. But with the GrassrootsHealth cohort, we have volunteers who have on their own chosen to take much larger amounts, up to as high as 9,000 international units a day, and they are available for study. So it's unique in that respect. Before the GrassrootsHealth cohort, the prize winner for highest serum vitamin D was the Rancho Bernardo study. It was conducted in California over a 40-year period, approximately. And it had a median serum 25-hydroxyvitamin D that some would consider high, of 45 nanograms per ml. That means that half the people had higher than 45 nanograms per ml. It was the highest cohort in the world. The intake in the Rancho Bernardo cohort is similar to that in the U.S. population of about 200 international units a day. But the people are out in the sun quite a lot, so they have 45 nanograms per milliliter of vitamin D, the 25-hydroxy metabolite, in their blood, which is similar to the Grassroots Health cohort. So it's a whole new world for science to have a cohort with such a very high intake, 18 times the background intake. And we're going to understand what vitamin D does for human health far better than at any time in history.
Thank you. So what were your findings regarding vitamin D serum levels and the risk of kidney stones?
We found that there was no association between intakes of vitamin D, even in this group that had this high intake, an average of 3,600 IU, and many of them were higher than that. And there just was no association. If you look for a trend, what you'd find is that the people that had the higher vitamin D in the cohort actually had fewer cases than the people who had the lower intake of vitamin D. So there was not even a trend suggestive that vitamin D was associated with a higher risk of kidney stones. And we followed these people for 19 months, so we know at least for 19 months there's no increase in risk. Doesn't rule out that there might be a slight increase in risk over a longer period of time, but we have no reason to believe that given the existing research from the group at Harvard and Curhan's group that looked at nurses over long periods of time and did not see any increase in kidney stones, although that was at a lower intake of vitamin D. But still, the higher women did not have a lower risk. It was actually the opposite.
Great. So one of the main figures for the paper is a mountain curve showing the vitamin D serum levels for those who developed kidney stones and those who did not, which is shown on the screen. Can you explain what this figure shows us?
Sure. This is a way of expressing data that is well suited to what are called rare events. And kidney stones are rare events. To the 2% or so of women who developed them in the previous clinical trial that I mentioned, was over a period of 15 years. So you have to divide that by 15, and that will tell you how many cases there are per year. So there are not very many. So the way that we analyze this is to draw this big mountain. It looks rather like the Matterhorn, I think, and it shows you the distribution of the serum 25-hydroxy vitamin D. And this is the standard measure of vitamin D. And that's what that curve shows you. The vertical line shows you the median at around 50 nanograms per ml. And so that's what the population is like. Then if you look at the little tiny black dots at the bottom, those are the people that got the kidney stones. Well, you'll see that there were 8 cases below the median and only 5 cases above the median, but there were an equal number of people below the median and above the median. So it means that there was just no association at all between 25-hydroxy vitamin D, the main vitamin D metabolite, and the risk of kidney stones in our cohort.
Thank you. So are your findings specific to a certain serum level range?
Well, our range was from 20 to 200 nanograms per ml, and to give that context, the average American's is about 24 nanograms per ml. So we've covered up to 5 times the typical serum level of vitamin D, and we've covered people up to 3,600 IU, which is 18 times the normal oral intake of vitamin D. So it's a very broad range, broadest ever.
Great, great. Did you assess any other risk factors, and what did you find?
Well, we looked at everything that was provided to us by the subjects, and we have a very detailed questionnaire, and we found that other risk factors didn't make much of a difference except for one, and it was body mass index. And what we found was that people that had a body mass index above 30 were 3 times as likely to get a kidney stone.
Interesting, interesting. So I'm glad you brought up BMI, because in your paper you mentioned that any associations previously found with high vitamin D supplementation and increased incidence of kidney stones may have been a result of BMI. Can you explain that a little bit further?
Oh, well, yes. If there were previous studies that could have found an association, it's probable that association was due to higher intake of supplements in people who were overweight, because often the doctor will recommend, or the person will realize, that if they weigh a little more, they're going to need a little more of whatever supplement it is they're taking. So that could create an artificial association between intake of supplements and risk of kidney stones. And the other thing is that in people who eat a little more, or even a lot more, they have a much higher intake of oxalate and other compounds that combine to form kidney stones. And it's much more likely to be that, because that would be a mechanism that's clearly identified than any direct adverse effect of either vitamin D or calcium.
Thank you. Were your findings consistent with other studies?
Yes, although no one has gone into this territory where no one has gone before, where we had just people that were at levels of vitamin D that have never been experienced. And so, yes, but to the extent that the studies have been done, and there's excellent work at Harvard on this, the higher the intake of calcium, the lower the risk of kidney stones, and the higher the intake of vitamin D, the lower the risk of kidney stones, to the point that the investigators at Harvard, led by Curhan and his colleagues, proposed that calcium should be used as a treatment for kidney stones because it ties up the oxalate in the intestine, and it never makes it to the kidney and never becomes a co-participant in the formation of a kidney stone. And in fact, enlightened doctors now treat patients who have recurrent kidney stones or from the kidney stone belt of the world with calcium in order to reduce the excretion of oxalate, and that has been found to reduce the incidence of kidney stones.
Great. So could vitamin D supplementation contribute to kidney stone risk for people with specific health conditions?
Oddly enough, it would be very rare, and it would be actually better for the person even if that happened to them. But there are some people that excrete a lot of oxalate. Some of them just love one particular food. It might be spinach, it might be taro leaves. There's some foods, rhubarb is a famous example, that if you eat a lot of them, you get a lot of oxalate in your urine. Well, if you have a lot of oxalate in the urine, then this happens in what we call the kidney stone belt. It's down in the southeastern part of the United States, although it does not extend into the southwestern part. If you eat a lot of those things, okra is another example, and you've had a very low intake of calcium, all of a sudden when you take in calcium and to some degree vitamin D, you could raise the level of calcium in the urine, and for a given amount of oxalate, it might form a stone. But that wouldn't be any reason to not take in vitamin D and calcium, because it means that you were at dangerously low levels. It is an indication to change your diet so that you don't consume as much oxalate. And even the University of California has a book called the Low Oxalate Diet Book. The university's gotten greatly interested in it. It's available for a nominal fee from the General Clinical Research Center at UC San Diego for people that are recurrent stone formers and want to know what foods are causing the oxalate excess or whatever ion it is that combines with calcium. But they're not being advised to reduce their calcium intake, because that would be an error. The calcium and the vitamin D are needed to prevent cancer, diabetes, reduce hypertension, and prevent multiple sclerosis, among other things.
Great. Are there any negative health consequences from taking too much vitamin D in supplements?
Well, there is a famous story of a man that formed a company that sold vitamin D by accident in quantities of 2 million international units per pill. And he took it, his friends, his family did, and they all were fine for several months. But as it came closer to a year, he noticed he wasn't feeling as good as he might. There were vague complaints. And he scrutinized the bottle, and he saw that the bottle contained 1,000 times as much vitamin D as was appropriate. So that was 2 million units of vitamin D. And you can, if you take 2 million units of vitamin D, end up feeling miserable. The condition did reverse itself. There were no fatalities or no permanent illnesses. So it takes an awfully large dose. But the organizations that are involved in this are very cautious, and they tell us to keep generally not higher than 10,000 international units of vitamin D a day. But that standard may change as time goes on. But if one gets into the millions, yes, it's harmful. The greatest risk is in children, and it mainly comes from errors in medication or supplementation. And it can occasionally cause, extremely rarely, fatal kidney failure in children. So you have to be careful about the dose, and certainly not give 1,000 times the dose, even though it's not that harmful apparently to adults.
Good to know, thank you. Is there a toxicity limit for serum levels?
Yes, and different studies reach different conclusions about it, but generally speaking, it's accepted as being 200 nanograms per milliliter. And we're trying to get people up to 40 to 60 nanograms per milliliter as part of GrassrootsHealth's educational efforts. So it's way less than the limit where toxicity begins. And that toxicity is, generally speaking, just an increase in serum calcium. It isn't an illness, it's just a change in a biochemical measure. It would take higher doses than that to actually produce a side effect that was perceptible to the patient.
Thank you. So why is the fear of kidney stones such a dangerous message?
Well, it's because it frightens doctors, it frightens people in general from taking enough vitamin D. And it's an irrational fear, and they don't realize that they would even be reducing their risk of kidney stones by taking it. So, but it is inhibitory, and we find that when we talk to local doctors and nurses and dietitians and people in general, that's the main complaint. They say, well, I might take it, but I don't want to get a kidney stone. My uncle had one, and it was miserable. And we commiserate with them because nobody wants to get a kidney stone. But the reality is that they are missing out on an opportunity to prevent breast cancer, bowel cancer, adult leukemia, kidney cancer, multiple sclerosis, type 1 diabetes, type 2 diabetes, by not taking adequate amounts of vitamin D, which is, for most people, at least 4,000 international units a day after age 9. So it's dangerous. It's putting them in a high-risk category for cancer and for diabetes.
Thank you. That's why we so appreciate a paper like this that really lessens the fear about vitamin D, which is unfounded, as we can see.
Absolutely. The more we can reduce that fear, the more the door will open to achieving the amazing reduction in cancer and diabetes that can result from taking enough vitamin D.
Yes, yes. So what is your recommendation for our viewers regarding optimum serum levels?
I would aim for 40 to 60 nanograms per milliliter. And this is a result of a consensus of vitamin D scientists and physicians throughout America who have joined together in a call for action that asks that everyone in the world be brought into the range of 40 to 60 nanograms per milliliter. And for most people in most countries, it will mean at least a doubling of their vitamin D intake. And for most people, it will mean taking at least 2,000 international units a day of vitamin D, at least 2,000 international units. And in some people, it will be higher. The upper limit established by the National Academy of Sciences for everyone age 9 and older is 4,000 international units per day, meaning most people would have no harm from taking that intake, and the benefit would be very great. So that should be kept in the back of one's mind. I also think that women may need higher levels of vitamin D, and we don't have a consensus yet, but I would say that we are migrating toward 80 or 90 nanograms per ml in women, because it takes a lot more vitamin D to prevent breast cancer than it does to prevent rickets, osteoporosis, bowel cancer, and multiple sclerosis. It really is something where, if we want to anticipate the future, it's going to be higher levels.
Great. Thank you so much, Dr. Garland, for joining us today. So ultimately, the findings from this study definitely lessen any concern about increasing vitamin D serum levels to within the range of 40 to 60 nanograms per milliliter, a level needed, as Dr. Garland mentioned, for substantial reduction in risk of a wide range of diseases. We appreciate your work on this topic and for joining us today to share these important findings. And if you're interested in reading this paper, you can find it in the most recent edition of the American Journal of Public Health or on our website at www.grassrootshealth.net. We have many exciting webinars coming up in the next few months. To give you a teaser, we will have Dr. Cedric Garland presenting on the association between vitamin D status and hospital-acquired infections. Also, Dr. Joellen Welsh will be discussing vitamin D and breast cancer, as well as Dr. Sarah Booth, who will be talking about vitamin K and vitamin D. Our next webinar is scheduled for Tuesday, November 12th at 10 a.m. Pacific Daylight Time, so be sure to mark your calendars. Please continue spreading the word about vitamin D, and we, Grassroots Health, can always benefit from more participation in the D Action Project. Information about the project can be found on our website at www.grassrootshealth.net. Thank you all for joining us today, and we look forward to you joining us for our next webinar.